Hello, good afternoon. Welcome to our multimodality imaging conference. My name is Isadora Matias. I am one of the advanced imaging fellows here at Houston Methodist and also a structural imaging fellow. And today we're going to discuss some interesting cases and kind of go over basics and not so basics of tricuspid edge-to-edge repair. So I have no disclosures for this talk. And this video is what you're not going to see today, which is a normal tricuspid valve. This is our QR code for attendance, review, etc. I'll give you a few seconds to grab a picture. So today in our talk, we're going to talk about a few different things before we dive into the cases. I wanted to first give a brief anatomy review of the tricuspid valve, an important kind of echo focus review, important echo views, and screening views for TE, what images you need to get for your TE when you're screening for tricuspid interventions in your lab. And patient selection, we're going to go over briefly, like what do we do with the data we find in those pictures on those TEs, and the kind of devices we have available currently, and then we're going to dive into a few cases that are each one unique in its own way. Okay. So just briefly going over the anatomy of the tricuspid valve. I know the name tricuspid kind of misleads us into thinking there are always 3 leaflets, but those can come from 2 leaflets to 5 leaflets, and they're divided by commissures, not clefts. This is important concept to understand. This valve is highly dynamic, and it can change area by 30% throughout the cardiac cycle, which has a very important role in how the valve remodels in response to loading conditions and in, for example, functional tricuspid regurgitation. These red dotted lines, they show the direction of the dilation of the virus structures surrounding the valve in the setting of secondary TR, which is the big chunk of all the TR cases that we see. A little bit of echo focus anatomy. I know we don't have any echo pictures here, but when this is kind of our quote unquote surgeon's view of the tricuspid valve and mitral valve, and you see the aortic valve in the middle in short axis, which this view we usually obtain as our inflow-outflow, both on TTE and on TEE. And I don't know if many of you have thought about it, but the tricuspid valve, if you're thinking about tricuspid clips and interventions, think about the tricuspid valve as a flipped, 90-degree flipped mitral valve. If you think about this as the smile commissure, as if you're thinking of a mitral valve anterior and posterior, this is how you have to start your thought process when you're developing your strategy to clip these patients. So it has, in general, anterior, septal, and posterior leaflets, which can be divided in smaller leaflets in some patients, 2 to 5 leaflets, as we mentioned before. And when you're trying to assess these leaflets on your TEE, as you, in your 4th chamber, which I'm going to talk in the next slide, as you go deeper into the deep esophageal, you're going to see more posterior. And if you go more mid-esophageal, you're going to see more septal anterior. And another thing that we're going to go over a lot here today is our inflow-outflow view. This is something that we see, the diagram right here on the left. But you see the aortic valve is a more anterior structure. So if you antiflex your TE probe, you're going to see more of the anterior septal coaptation. And if you retroflex more, you're going to see more of the septal posterior coaptation. And this is when you're getting farther from the aortic valve. And I'll show examples of all of that. Another clue for when you're in the 4th chamber and you're going deeper with your probe is when you see the coronary sinus, you're usually seeing the septal posterior coaptation, which is what you see here on the left, but you can also see from our retroflexion. And when you are not seeing the CS, or you start seeing, for example, the aortic valve, when you're really kind of shallow into the esophageal views, you see the anterior and the septal leaflets. And this is very important, not only to understand how is this jet, where it's coming from, but also to plan your procedure and kind of build your strategy when you're sending a patient for a tricuspid clip. So just briefly talking about TTE, I know we do a lot of those quote-unquote pre-triclip, pre-tricuspid tier TTEs. And I feel like the most important thing for those, besides quantitation, which is the patient's gonna come to you in their usual loading conditions, like from home, and that's the best time for quantitation because you're gonna be able to measure a better vena contracta, and sometimes PISA is a little more complicated and tricuspid. We're not gonna go into that because that's not the purpose of today, but the TTE is better than the TE from that sense because the loading conditions are optimal. But aside from that, it's very important to get multiple views of the tricuspid valve to be able to see a jet that may not be seen in a different view. For example, you may not see a lot of DR on a four-chamber view or RV focus view, and then you go into your inflow view or your short axis view, and then you see much more of a coaptation gap in a TR jet. So this is one of the patients we're gonna talk about today when we go deep dive on the cases. Hang with me, this is a very busy slide, but we're gonna go over all the steps to assess in a TE a patient candidacy. So our main working view, and it's kind of our workhorse for TTR assessment, is our inflow-outflow. So let's focus on these two on the right, on these two videos on the right. So this is an explain of the inflow-outflow. And I highlighted the explain line here in yellow, so we can see that where it's crossing. So this is our tricuspid valve, as we know. Here is our tricuspid valve, so very same view, around 60 degrees. Here I'm explaining closer to the aortic valve. So that's gonna give me a anterior, this is septal and an anterior leaflet. We also say sometimes, especially when we're doing dedicated views, of these, we can call this leaflet lateral leaflet, which we sometimes don't know if it's anterior or posterior. But in this case, we know it is anterior because we're crossing very close to the aortic valve. So on this one, we moved our explain a little bit towards the side, away from the aortic valve, and that's gonna give us septal posterior coaptation. As you can see, the septal posterior jet is much more prominent than the septal anterior, and here we see pacemaker lead that we do not see here. So we're definitely explaining through across different coaptation zones. That's very important when you're doing your baseline TE to understand where the jet's located, to understand things like lead impingement when you have a lead, and to kind of start to measure your septal leaflet, which I'll talk in just a second about, and to kind of plan overall your procedure. So here, if we jump down to this still shot here, we can see that on that posterior septal coaptation zone, we can measure the septal leaflet, which is right here. And this is very important for our tricuspid clip planning and patient candidacy. We would like the septal leaflet to be more than 0.7 centimeters for the biggest clip. We can work with smaller, but not always. That's not always an easy case. Here is a 3D just to show everything at once, sort of like make you understand the big picture of this valve and the surrounding structures. Same kind of surgeon's view that we're seeing. And here we can see one of the leads nicely tucked in the interseptal commissure. And there is another lead here that we were able to see once we did the 3D, which is more posterior septal, and it's kind of not freely moving, but more mobile. So this is the ideal case, lead nicely tucked into a commissure. And this case is not as ideal, but we can work on it because we could find a grasping view where we don't see any leads. Here is our transgastric short axis, super important view when we're thinking about triclips. And here you can see that the biggest coaptation zone, the largest coaptation zone is going to be your posterior septal. But it's pretty much a central jet, but the biggest gap is going to be here. Okay, so on the bottom right, we're almost done with this slide. It's important also to look at your transgastric view for lead impingement assessment. When you explain through a lead on a transgastric, you can see the relationship between the lead and the leaflet. In this case, we can see here. So this is going to be our posterior septal, quote unquote, lead in the blue arrow. And then the yellow arrow is going to be our anterior septal lead. And none of them seem to be interacting with the leaflets. You don't see the leaflet held by the lead. And at the ideal scenario here, it's really in the commissure. You can't really see it interacting with any of the leaflets. All right. Oh, important to say that this, when you explain like that, this is not the coaptation gap. So the red lines are not our coaptation gap. Our coaptation gaps, they are in between our septal anterior and our septal posterior leaflets. And if you measure this as a coaptation gap, you can erroneously tell a patient that they cannot go for a tricuspid clip because that's not the orientation of where we're going to clip. It's almost like we're looking into commissure to commissure in the mitral valve, for example. So just a word on NPR. Very helpful to develop your 3D view that you want to work with. There are cases where we can work completely with NPR to place our tricuspid TEER device. And it's very helpful for overall, to understand the surrounding structures, the leads, and the relationship between the clip you're going to place and those leads. We're going to go over more NPR in one of the 4 cases that we're talking about. So I really like this flow chart, and it's very easy, very simple to understand. When you're doing a TE to screen a patient for a tricuspid clip, the first decision point that you're going to make is this coaptation gap feasible? So the coaptation gap more than 7.2 millimeters is usually going to put you in the orange-red zone. So those are more tricky cases. We need more expert centers and etc. If it's smaller than 7.2, then it's going to be more on the green-yellow line. So after you decide that, you see where the jet's located. The ideal place for the jet is central or septal anterior, because this is the easiest place to place a clip. But if the jet is a little more posterior septal, you can still work with it. I would classify the patient we just discussed here in the yellow zone. So it's doable, but we're going to have some challenges, like the leads and the posterior septal jet. Here are the current commercially available devices that we have. For the tricuspid triclip, we have all this alphabet soup here that pretty much define if the clip is long or wide. So W stands for wide and X stands for long. And here are the devices that we have available. XTW is the long and wide device, and it's the one that we always try to use first because it will usually reduce the amount of clips that you need to place. For the generative MR, we have approved the Pascal and the Pascal Ace from Edwards. And now we're going to go over the cases. And I'm happy to take questions at the end. I believe we're going to be a little ahead of time. So this case 1 was a straightforward case. This is a 78-year-old female with a history of AVR and MV repair, had symptomatic functional MR. Relatively straightforward, no pacemaker leads, but she had some hardware that could impair our visualization. So this is our screening TE. where we can see that although there is a mitral valve ring, we're still able to see the tricuspid leaflets. We see severe TR, and we see our coaptation gap here that was measured at 6 millimeters. The jet was central, and we know that the potential issues were two bioprostheses and potential need for ICE. It's important, I know we can have ICE, and at least in our institution, we can always request it if we need to, but it's important for the imager to expect, to know when you're gonna need ICE, so the procedure runs more smoothly and we know what to expect, the views that we're gonna get. So in this case, we move on to interprocedural. On the top left here, we see our bicaval view in which we usually start directing our clip towards the tricuspid valve. The catheter is here, and the clip is straddled and closed towards, it's kind of facing towards the SVC. And here's gonna be your tricuspid valve. So we're gonna aim towards the tricuspid valve. And then after we've done that, we're gonna go to our quote unquote workhorse, which is our inflow outflow view, and go through the explain to locate our clip and test the grippers. So here the clip is closed, here the clip is open. And when I say test the gripper, it's pretty much our triclips have 2 arms, and those arms have each one their gripper. So with the gripper, you will pretty much sandwich each leaflet, one side, the other side, and bring it together to coapt the leaflets. So here's when we test them, when they are right open in front of us. And on the right here, we're gonna also assess the trajectory of this clip to see that when we advance, is it gonna change direction, or are we on the right direction, etc. Here on the bottom left, it's another very important view, which is the transgastric short axis. On this one, we need to look at our clip orientation. So the clip is open. We know it's in septal anterior, as we can see on the top middle. But we want to know if it's nicely close to the commissure. So we try to go first anteroseptal, because that's the highest rate of success, and we can always go more posterior as we go. And we try to go as close to the commissure as possible. So here we are orienting the clip. We can always clock, counterclock, and this is a lot of back and forth discussions with our interventionalists. On the next view, we're gonna be ready to grasp. It is important that we get a dedicated grasping view. So here we found out kind of where it would be, and then here we did a color compare. We do the color compare to confirm that that's gonna be the region of interest. Like if we're grasping the leaflets where your jet is the biggest. So after that, we grasp the leaflets and we feel them nicely tucked into our closed clip. And after that, you will see on the transgastric a nice tissue bridge and one of your clips here. Okay. So next step is to assess for any residual TR. Here we still had some residual. So we went ahead, and I'm not gonna go over the whole process again, but we went ahead and placed a second clip. We see this is the first clip, this is the second clip, and on here we try to make it as close as possible. Also orienting on our transgastric, and then this is the 2 clips together with trace residual. So I don't know why this is blinking green, but you can see the 2 clips together. Here in another view with minor residual TR. All right, so case 2, I'm gonna go over very briefly. I think the videos are not playing, which is sad, but we'll jump forward. But this was a patient that underwent orthotopic heart transplant years ago, developed flail tricuspid leaflet from multiple biopsies. Ended up getting a surgical tricuspid replacement with a band, repair with a band, and still developed recurrent flail. So on this picture, if it played, you would have seen the flail leaflet here with severe TR, and here you would also be able to see it. We did an MPR, but we'll go more into details on this on the last case. Placed the clip, and we had a successful result with 2 clips in this patient. So these 2 fluoroscopic pictures here are good for you to see the clip in relationship to the tricuspid valve. So this is the band. So this is where the annulus should be, and this is the first clip being placed, and these are the 2 final clips in place. And this is kind of how it looks like. So case 3 is interesting because we had to use ice in this case. These videos were all playing yesterday. So we were screening, we looked at our grasping views, found our coaptation gap, measure our septal leaflet, just like all the steps that we talked about. And then we started to place our first clip, but we realized that our grasping views weren't optimal to be able to see those clips and those leaflets and grasp. So here we do a lot of back and forth. That's why I placed this little arrow here for you to understand that this is what we do live in the cath lab. So we go back and forth between TEE and ICE to be able to position the clip with transgastric TE, orient the direction of the clip, and then we move to ICE for grasping. So this is an ICE view. The clip is open here, and the leaflets are ready to be grasped. And here is after the grasping happens, you just see that the 2 leaflets are tucked into the clip. And this is our final result with mild residual TR, and this is our clip. All right, so the last case that we're gonna discuss here is a case that Dr. Little and Catherine did yesterday, which is also a case that we discussed on the screening. So just for it's the case that we showed for screening because it has very good pictures. But the interesting aspect of this patient's case is that we used MPR for the whole case, for a good part of the case. So it did not require ICE, and it shows like how helpful can be an MPR construction. So I'll go through each step of your MPR assessment. So first, we get our initial 3D, and we go onto our MPR view on the machine. And our goal is to align the blue line to our annulus and the green line to the catheter that's holding the clip to obtain the best set of views possible and do the orienting that we showed you on the other cases, and to also show the moment that the clip's crossing the valve and position in relationship to hardware like leads, for example. So we can do all in one. You don't have to be toggling around the different views and reobtaining them. So on this one, it's the same view as the other one, but now we moved our green plane to the catheter, as I mentioned, and then aligned the blue to the annulus. So here is going to be our green view with a clip in the catheter, and here we can see the interoceptal lead. And here it's the 3D result of that. So move the yes. So Dr. Little just corrected me. So we don't move the green line to the catheter. We move our catheter towards the green line with the discussions with our interventionalists, so we can position correctly. So with that, you get a whole data set of the trajectory of the clip orientation. Like, for example, this is the aortic valve, and this is the tricuspid valve, and you know the depth as well before you cross the valve. And here you have the entire data set for orientation of like the clock or counterclockwise orientation, which you're going to see on the next view. If this video quality, yeah, good. So here, see, we rotated the clip to orient it better to the interoceptal. And this is, with this whole data set, you can perform the grasping if you want. Ideally, for grasping itself, because it's such a critical moment, you go dedicated and you do the following steps that we discussed on previous cases, so I'm not going to go into detail on that. So this is preparing to grasp. Here we get closer to the leaflets. And here we check if the collar is at the same spot. And here the clip is closed, and we finalized that first interoceptal clip. And that was right in front of the lead that was tucked into the interoceptal commissure. So in this case, we decided to place a second clip. And this second clip was placed right in front of that posterior septal commissure. If you remember this case from the very beginning, you remember that the biggest gap on this patient was posterior septal. So we wonder why we didn't clip posterior septal first. And I was having that discussion with Dr. Little just yesterday. And this is one of the things that you want to avoid doing is you do first your interoceptal, because if you do the posterior septal first, you're going to cause shadowing, and you may make it more difficult for you to clip interoceptal later. So we always, well, most of the times, we don't say always, but most of the times we're going to start by clipping the interoceptal. And in this case, it was interesting because we jailed both leads with the clips. So this is the interoceptal clip, the posterior septal clip, the interoceptal lead, and the posterior septal lead. And this was our final result with mild TR. This video, unfortunately, I apologize, is not playing. So just a few take-home points before we answer questions, and Dr. Little is here to help with that as well. For TTE, very important to look at the jet in multiple views, and to look at the inflow gradient. So let's say one of the echo techs here is looking at the patient's TTE in the hospital after one of these procedures. Very important to look at the gradient to assess the jet in multiple views, and do a lot of focus on the RV and RV function, etc. On the screening TE, most important is to measure an appropriate coaptation gap, because that's going to be the decision point, one of the most important decision point in terms of sending this patient for a clip or not. With a caveat that some patients, this is a very dynamic valve, so in some patients we can send these patients for diuresis, even IV diuresis before the procedure, and we can try to decrease these gaps. If you have leads, you have to think about it. Is it a culprit to the mechanism, or it's just there? And if it's just there, how can we work around it? Can we work around it? And the jet location, to think about our strategy, the measurement of the septal leaflet, to think about clip sizing and feasibility, and then anticipate, are we going to think of needing ice on this patient, or likely not? We're open for any questions, and I'm sorry for the videos that were not playing. This was unexpected. Thank you.
Everybody's ready to do a tri-clip? Okay. Any questions? The NPR, anything?
Why do you switch between ice? What's the reason to switch between an ice and a TE, and are they on the same console? Give us a feel for that.
I can take that one. So usually we will switch between ice and TE when the TE images are suboptimal to visualize the grasping. So let's say on our high angle view where we have our RV on the right and the coaptation gap there, if we don't see the septal leaflet very well, let's say that patient has a lead that's shadowing the septal leaflet or something in those sense, like some some other hardware, then when we use ice, we may get rid of that artifact and be able to see those leaflets better. It is here, at least, I don't know, I can't speak for other centers, but here we use it in the same console. So we connect the ice, and the imager drives the capture and kind of the zooming, the color, the angle for the ice, and the interventionalist will manage the ice catheter itself to acquire the images.
So that's all correct. One of the fundamental things for ice is that the esophagus is often off to the right in relation, so the left side, excuse me, in relation to the tricuspid valve. So you often have to look through left-sided structures. So you've got to see through your Watchman, through your ASD occluder, through your TAVR, through your mitral. So you've got to look through all this hardware to get to the tricuspid from the orientation of the esophagus. But ice has the advantage, you're coming from the other side, it doesn't have to look through any of that stuff. So fundamentally, it's just unshadowed. So when you have a bad shadow, often left-sided prosthetic material, or just sometimes just bad luck and horizontal heart and things are far away. So the ice is fundamentally looking from a different location. So some of it is the frequency and things like that, but some of it is just the advantage of not having to look through the same things and being much closer.
So the follow-up question is, why not just use ice?
One very practical concern is the chairman wouldn't like it. It's a $3,000 add-on. So the 3D ice catheter is roughly $3,000 single-use disposable with no additional code for it. So it comes out of the DRG. So it's a huge added cost for every. So if a procedure is marginally positive or even slightly negative, it becomes definitely negative and more negative. So it's a big cost issue for one. Also, it's very tomographic. It's zoomed in. You don't have much depth. You only see one thing. Practically, it relies on the IC for all the coordination of it, which is frustrating because you don't actually control the image. You can advise, but you can't actually move it around.
Unless you scrub with them.
Yeah,
Yes.
unless you're doing it, and then you're not doing the console. So it's always a compliment. You know, I would say currently the only time we would ever consider ice alone is if somebody did not have an esophagus.
Yeah.
And how often, for tricuspid, obviously, how often do you use it?
I would say, what, 90% of the times?
No,
80%
less
of
than
the times?
that. Used to be 0. So we cut our teeth with no ice, and then it was a 2D ice, and then it was a 3D ice that wasn't Phillips, so it wasn't integrated into the box. So it was more challenging because they would actually interfere with each other. You had to pause one and start the other one, and it was a little painful, but now it's all one console. You just toggle between them, which is just like going between a transthoracic and a TE probe. It's just a single button. Yeah, and then, no, we're thinking around
percent-wise?
60%. And yeah, which makes sense because from 4 cases that we showed today, I think only one we used,
Yeah.
one or two we used
We
ice.
anticipated we would need it on the case you showed. This case had 2 mitral clips, 2 RV pacer leads. That's a lot of hardware. Complex jet. We thought we would need ice. But the approach is open it when we need it. So we had it in the room. The discussion was, should we open it? I said, no, let's not spend the money till we have to. And let's just try with T. And then as soon as you get to a point where if you know this hardware and you've struggled, you'll give it 5 minutes. And if you can't see it, crack the ice box. But if you can get it without ice, we try to not use ice. Mostly a cost issue. Otherwise, we'd add it to everybody.
Yeah. But still, like, we wouldn't be, I think that it wouldn't be, it's not only the cost issues, everything that Dr. Little said is very tomographic, and with the TE, you can see a more comprehensive picture, and I think we can kind of easily get to the views that we want. So mostly for grasping, we've been using it.
It's akin to trying to do a complex T only with the zoom mode. That would be a little frustrating.
Who decides on the size of the clip?
Great
the short,
question.
the wide, the long?
That's a great question. It's, at least in our institution, which is something that I'm very proud of, is a shared decision. So we discuss with our interventionalists before they walk in when we're doing, we screen the patient before, and we screen the patient again when the patient comes in and is fully under anesthesia.
But what goes in the decision?
Yes,
Meaning,
so size of the septal leaflet in the mitral clip would be size of the posterior leaflet at your grasping zone. So it can't be anywhere. It has to be where you're planning to grasp. Something else is the gradient. So that's not usually a problem for tricuspid because we have a big inflow area. But on the mitral valve, let's say we have a little bit of a higher inflow gradient, then we may think about doing a smaller clip, or even like if it's a tricky location for placement of the clip. Dr. Little?
Yeah, the vast majority, we go long and fat. We don't do a lot of, so the tricuspid is almost exclusively XTW, which is a long one, fat one. You've got lots of diastolic area, redundancy. I don't know that we've ever, since we've had the availability of the long fat clip, used a smaller one in the tricuspid space. But in the mitral space, it's a little more nuanced, as Isa said. Sometimes if you get into the commissure and there's a lot of cords and you don't want to mess that up, you will go a smaller clip. But even the vast majority of the time, it's a big clip. But individual to the patient, you have to see how much diastolic area you have, how tight do you want to make the valve. That's part of the pre-planning huddle. We do some baseline images, we talk to interventionalists, and we're thinking this clip for this reason. And they always say, yes, of course.
Do you measure the length of the posterior leaflet?
We do.
Yes.
Every time.
Right, for that?
Yes. As we measure the septal on the tricuspid, we measure the posterior for the mitral, and it has to be where you're planning to grasp.
So follow that up. So 2 critical points on the screening TE. Typically, it's, most of the time, not always, most of the time, you're going to go A2, P2 on a mitral clip. So a length of P2 is very important, a curved length. So not a straight length, but there's a button on the Phillips to measure a curved length, because that's 1 or 2 millimeters longer than a straight length. So we need that measurement and the diastolic area. So a good 3D of the mitral valve for diastolic area, because if it's less than 4 on an average-sized person, it's very hard to get a clip on there without creating significant stenosis. So that's an important measurement. Tricuspid, so much more forgiving because it's such a big area. Annulus. Yeah.
You may have mentioned this earlier, but for tricuspid,
I'm sorry.
Tips.
Sorry,
Yeah,
sorry, I was thinking MS.
Something
Tips,
different.
tips.
Yeah, leaflet tips. So we do a 3D MPR. We do a 3D. We get a 3D, and then we can do offline or on the machine an MPR, and we get to the tips and measure the area.
Sorry, Dr. Q?
yeah, as you have been learning with the tricuspid and doing more cases, are you lowering the bar for who gets the clip, i.e., severity of TR? Are you still doing the so-called torrentials, or are you also now moving more towards just plain severe? 1. Number 2, symptom-wise. Like, I'm following at least 4 or 5 people with bad TR, but they are okay. They're functioning okay. They may be class 2. I'm holding because, this is a new procedure. How are you doing now in terms of lowering that bar and tackling less symptomatic and perhaps less severe in terms of being not being torrential?
You want to start?
Yeah, so I think one of them, of course, like on the torrential patients, we plan to try to help them out because they're very symptomatic. But one of the things is the patient itself. Is the patient very symptomatic and they only have severe? We fully medically optimized. We don't have anything else to potentially offer. Yes, and they're a good candidate. We would try to go and clip that patient. But mostly, it's gonna kind of go together. The more symptomatic with the more severe. And it also depends on the loading conditions, as we mentioned during the talk, is that some of these patients you're going to diurese before, and they're going to come to you to the day of the procedure more looking like a severe, massive instead of torrential.
So you still don't want to tackle like a class 2 person who's doing more or less okay, maybe a little bit of edema, but not much. I mean, that kind of a patient you still would follow for a while?
I would say we're getting there. If it's severe with any symptoms, let's go after them. The history is interesting. So we started doing this therapy with drive-by mitral clips. Right. The way the finances worked, the Abbott is incredibly smart with this. The bill is for the catheter, not the clips. Always has been. So if you do 1 clip or 4 clips in the mitral space, it's the same bill. So they just want to get outcome. So you pay for the catheter. And the idea is, once you've done that on a mitral case, put 1 clip, 2 clip, 3 clip, whatever, if the patient had significant TR, you would do it on the way out. Because you've already paid for the catheter. Clips are free. Drop a clip on the tricuspid. That's how us and a lot of centers learned how to do this in the early days. Drive-by. That took 4 hours. But it was only 1 clip. It was a small little short clip. So the shortest, thinnest version of the current clips was called the NT. That's all we had. And it was terrible. The catheter wasn't designed for it. It was a mitral catheter. All the bends were wrong. Really difficult. One size, small. And you could only do tiny gaps because you just couldn't get it with the clips wasn't big enough. And then in the COAP trial, we got a big clip. You could close each arm singly. The catheter was actually designed for it. But it was very conservative because it's a trial. You want good outcomes. So they would exclude all big gaps. So what's happening clinically, to your question, is we are going after bigger ones now. So, the gap, if 7 is ideal, 7 or less, 7.2, I don't know where the 0.2 comes from, but 7 is what we think about. Less than 7 is a green case, you want that. More than 7 is challenging. More than 10 or 11 is probably hard to do, but 7 to 11 is doable, but you do it differently. You do zip and clip. You sort of start in the commuters and work your way where you sort of pinch so that by the time you get to the 11, it's now 7 because you've pinched a little bit on the way. So these are the sorts of things you can do now that we have newer clips and better catheters. And the other big thing that's happened is we've learned how to do the imaging. We first started, we didn't know about the short axis view and the inflow view, and we were just putting the probe everywhere trying to see anything. So the whole field has decided, here's some fundamental views. Let's learn the fundamental views, and then things get a lot easier. So it's a cookbook now. Yeah.
Yep. Any other questions from the fellows or from the echo techs?
Yeah, the big question we have clinically is who gets TEER and who gets TTVR? And that's the big question. And then who gets a cable device, which is the trial. And this comes up all the time. So if somebody has torrential TR and the gap is upper end, challenging TriClip, but possible probably, do you try? Or do you just skip that and go right to a TTVR, which is now commercially available? And if the annulus is too big, or when do you do, the trick valve, which is a cable valve and an SVC valve, one and the other. Forget the RA, burn the boats, just prevent V waves from going to, protect the liver, protect the head. That's it. Forget the RA. If you're already in AFib, for example, let it go. Go after your other target. So these are the thresholds now is who do you even do this therapy on, and when do you go? And
or after?
You would think so.
You would think, yeah.
But people have done that a couple times. So if you have one TriClip in a corner, you can squish the hell out of it and put it over here.
Putting the long and the larger one, XTW now. Because the reality is if say the clip is not as good, if you compare it on a randomized controlled trial, is not as good as your valve or your trick valve, then would you be doing disservice or not? Now it's probably too early, but what's your experience with these two?
There's no trial planned or coming that I know of. Industry would rather you have both on the shelf and pick and choose. They're not going to prove one's worse than the other, not for the $100 million that's going to take to do that. But there's different things, right? I mean, the argument that always comes up is the RV pop-off. The TriClip was not perfect. You will leave some TR. And if you're doing it in a sick RV, is that a good thing? Do you want to have no pop-off on a sick RV? The TTVR, very good at TR reduction. You're going to go to 0 TR, but you also paralyze the annulus because you have this, annulus paralysis. You've stuck this thing in the annulus. It's not going to contract. It's barely going to have any descent. How is the RV going to take that? So the theory is some fail, and that has happened. So no RVs fail with a TriClip because it's not perfect. It leaves a little hole. So do you want that hole or not? So there's all kinds of debate about which RV is too sick for a TTVR. And now those are when you go to cable devices.
And in the mitral world with,
Yeah, the TTVRs need anticoagulation, and that's another big, we don't know. Early days but then they're starting to have more and more reports of thrombosis because it's, massive atria. Even without AFib, they can't, if AFib, they get anticoagulation, but they have to be anticoagulated for at least 3 months, and there's signs that maybe that 3 months should be longer. Even without the anticoagulation, they still get structural valve deterioration, just like any prosthetic valve. The clips don't deteriorate. The tissue around them might, but the clips don't deteriorate. So there's a lot of different camps and a lot of opinion, but actually no data.
Yeah. I think in the mitral world, just to kind of complement Anish's question, we've done situations in where we slice the clip and put an actual valve in it.
We haven't yet.
Like an Avasta or...
It's described to slice off the anterior leaflet and let the clip fall in the posterior. And do a the collective, we have done it, but Methodists have not. Not done the Elasta yet. But you're right, it's an opportunity cost. If you do a TEER, it generally means you can't do a valve implant after that. It has to work or it doesn't work. Yep. All right. Good. Thank you all. Thank you, Isa.
Thanks, everybody.